just upload my slides from my end, right?
Mm-hmm.
For airborne diseases. I hope some of you or many of you or maybe all of you joined the previous 2 webinars. In case you have missed it, it is available on the Stop TB website for you to download. Not download, you can actually watch it there on the website. This is an initiative by Stop TB Partnership and ETTI Working Group, which is a working group of Stop TB Partnership and TB Transmission Initiative, which focuses on airborne infection control. Airborne infection control, as you all know, many of us have been highlighting it as an issue for TB, but the COVID pandemic has put it right in the center of everybody's life in healthcare and everywhere. So I think this is now a very important topic, and very good that people are joining every Tuesday to both learn about it and also ask questions which are very interesting, which also helps the ATTI working group and all of us to think even more and get more information about it, and also encourages people to work and gather more experience on many things that are currently known as well as unknown. So without further delay, we will go to our presenters for today. We have 3 presentations. We have 90 minutes of time, 3 presentations. We will have first Dr. Grigory Volchikov from the Regional TB Control Center in Vladimir in Russia, talking about airborne infection administrative control strategies. Then we will have 2 interesting country experiences. So far, if you recall the previous 2 webinars, we didn't have countries speaking. Today we have South Africa and China. Dr. Matse Mafahle, I'm sorry if I'm not pronouncing your last name correctly. She's from South Africa, from the infection prevention, she's infection prevention control advisor, USAID Tuberculosis South Africa project. Then we have from China, Dr. Liu Yuhong, Director Assistant, Director of Managing Office, National Clinical Center on Tuberculosis, China CDC. Also China Tuberculosis Clinical Trial Consortium, Beijing Chest Hospital, Beijing TB and Thoracic Tumor Research Institute. So 3 speakers we have. I would now hand over to Carrie. Do you want to say something from the ETTI in the beginning?
Good morning, good afternoon, good evening, everyone. No, Sahu, I think we can go ahead and get started, and we can, so we have time for maybe discussion at the end, but I think that you did an excellent introduction.
Excellent. And just to let you know, those who don't know me, I am Suvanand Sahu. I work as Deputy Executive Director in Stop TB Partnership in Geneva. So over to Gregory. Please go ahead. The floor is yours.
Thank you, Sahu, for introduction. And my talk will be on administrative measures to control airborne infections transmission. And I will give the overview of this extremely important part of the airborne infection prevention and control. This is really a special time we now live in, and every healthcare worker, every healthcare facility is in this fight with the pandemic. The population is also very concerned, and I would like to share with you the experience and my vision on this problem. And actually we will discuss both TB and other airborne infections prevention measures. And I would like to start from the WHO guideline published last year in April. And it is so far the only airborne infection control guideline recently developed and functional. So TB is a very well-known disease, and it's everybody agrees and no any skeptics about the airborne transmission of this infection. But there is evidence that COVID is also transmitted, at least partly, but probably substantially through the airborne route. So WHO guidelines as evidence-based document developed by the group of the experts, and it was updated last year, and includes complex of effective recommendations of effective measures to control, to reduce, to eliminate the risk of airborne transmission of TB. But it's quite applicable for other airborne infections. The basic principles are actually the same to prevent the infection. There are some specifics for TB prevention in this document, but again, these recommendations can be used for COVID airborne transmission prevention. We have to keep in mind that COVID is transmitted through also direct contact, through a droplet route of transmission, but also there is evidence published and discussed now, growing evidence that COVID is transmitted through the airborne route. You see in the left upper corner of this slide, the very nice drawing of daughter of the presenter to the Yu Hong Liu. Cheryl, please mute your microphone. Thank you. So this is the picture of the nurses, doctors who help each other to prepare to work in high-risk settings. So they actually put on the lab coats, caps, masks, respirators to enter into high transmission risk area. And you see the very impressive eyes of the first person who is looking into our side. And we see the concern and hope that she is protected. But it doesn't happen actually in many countries and many hospitals, that many people do work unprotected, in fact, and we have information that many lethal cases among staff still occur. I would say it was the same for TB when I started to work 20 years ago in TB control in Russia. There were lots of occupational TB. There were lethal cases among healthcare workers in my facility. So we'll discuss what can be done in this regard. And I would like to mention a few publications which actually build the basis for theory that COVID is transmitted through the air as well as through the droplet and direct contact. In 2017 in Russia, in Siberia, the researchers investigated the stability and survival of the artificial aerosols of the Middle East respiratory syndrome, MERS-CoV. And they found that at room temperature and normal humidity, such aerosols remain stable and alive and are able to transmit the infection for more than an hour. At least 63.5% remain stable in fine aerosols in the air. With less humidity, the survival rate of the aerosols was reduced, but still the fact that the coronaviruses can be stable and alive in the aerosol in the air. There was also an interesting article in the Science journal recently in May, in 27th of May, called Reducing Transmission of SARS-CoV-2. And the authors, they claim that the large proportion of the spread of coronavirus disease, COVID-19, appears to be occurring through the airborne transmission, through the fine aerosols. There is a very important also thought was expressed that the severity of COVID disease, the severity of the pneumonia, which actually kills most of the victims of this disease, is a massive transmission through the fine particles. which are able to go through the tracheobronchial tree and reach the deepest lung alveoli, and to cause the massive pneumonia, which causes the severe complication of the disease. The next article I would like to mention is transmission potential of SARS-CoV-2 in viral shedding observed in the University of Nebraska Medical Center. So the authors also analyzed the shedding of the aerosols by the infectious patients with the minimal symptoms, and they found that the transmission occurs not just through the large droplet, classical droplet transmission, not just through the fomites, but for the aerosols as well. So what also is important that our countries, I show you here the few pictures from Russia, from my native country, and I see around lots of actually chaotic actions, chaotic measures implemented, waste of resources and loss of lives because of that. It's like one picture is showing the disinfection of the streets and squares in Moscow, in the capital, wasting millions and millions of rubles without any effect, we understand. Also implementation of useless PPE for chemicals, like gas masks, and complete suits for chemical weapons in these settings. And also the one picture is showing the religious procedure around the hospital after death of several healthcare workers occurred in the hospital is converted for COVID. And now the last resort is just praying in this situation. So the adequate preparedness matters. And we see in the hospital the plastic windows, the air conditioners installed, and blocked natural ventilation. So let's say what's said in the WHO guideline on airborne infection control and TB infection control. It includes actually 7 very general recommendations of effective interventions which are proven to be effective in terms of reduction of airborne transmission of TB. And the first recommendation is triage of people with signs and symptoms or with TB disease is effective in reduction of the transmission. And it reduces the risk for patients, for people who are visiting the facilities. And this triage is absolutely applicable for any kind of infection, and including airborne infection. The second is a respiratory separation, isolation of people with presumed or demonstrated infectious TB or infectious COVID. And it is also effective recommendation. And next 2 webinars next weeks, there will be discussion of environmental controls and about how can we organize, how can we offer effective respiratory separation and isolation of sources of the infection and to reduce the transmission. So it will be discussed in detail next weeks. The third recommendation is more about TB, not COVID. Unfortunately, effective treatment for COVID is not yet available. At least we do not know about the impact of the treatment on infectiousness of the patients. But for TB, it's proven that the effective therapy reduces the risk almost instantly, a risk of transmission of the TB disease. I hope in future we'll have drugs for TB and other airborne infections, which will work as effective as TB drugs against the transmission. The fourth recommendation about the respiratory hygiene, including cough hygiene in people with presumed or confirmed TB in terms of reduction of TB transmission. It's absolutely applicable for all airborne infections, including COVID. So respiratory hygiene, use of masks, cloth masks or medical masks. It was discussed 2 weeks ago in the webinar. The webinar is available online in ETTI webpage. And this is the measure to effectively reduce the concentration of aerosol in the air where the sources can exist. There are two environmental controls included into this guideline. First is upper room UVGI. One of the webinars will be dedicated to this measure. And I would say that the administrative organization of effective use of UVGI is extremely important. I would say that the administrative controls, they are basis for all the interventions effective for reduction of airborne infections. So we have to understand what is UV, how it should be applied, how it should be installed, what kind of design do we need, what kind of maintenance it requires, and so on. The next recommendation, any kind of ventilation, mechanical, natural, or mixed mode, or recirculated air. This is very special. This is classical intervention to reduce the concentration of airborne infections. Will be two next webinars next week, and the week after the next one will be dedicated to ventilation system. And again, we need to administratively organize effective installation, design first, installation, maintenance, use. We have to educate the patients, the healthcare workers about the use of the ventilation, natural, mechanical, whatever. And the last recommendation in this WHO guideline is absolutely applicable for all airborne infections. It's about the particulate respirators, and not just respirators, but the in framework of the program, respiratory protection program. So organizational program is effective in terms of reduction of the transmission risk. I would say it's not just enough to supply respirators. We have to train, to educate people how to correctly don, where, when, for how long, how to dispose, and so on. The first webinar 2 weeks ago was dedicated to this topic, and again, it's available. Just check the website, the webpage of ETTI in the internet. So Paul Jensen introduced the hierarchy of controls of airborne infection controls, and the basis of all interventions again is administrative controls. It's complex of measure which allows to concentrate, to localize the risk in certain settings, to prepare effective use of environmental resources and use of personal respiratory protection in high-risk areas. And again, it's a theory about all airborne infections, not just about only TB. And I mentioned already the high occupational risk in my facility, which was 20 years ago. And we monitored occupational TB and infection among healthcare workers of the facility which are responsible for TB control in my region. So we realized that after a few years, just 3-4 years after the introduction of the complex of measures, we are able to reduce the risk. Now in the COVID situation, we actually have no such years, but we are limited in time very much. But the measures are already known, and our mission is to deliver this message to the healthcare facilities which are now converted, which have no such experience in the airborne infection control, to train and to teach them to work in a safe way to protect healthcare workers and to reduce the transmission risk in hospitals. So this table shows the actually much higher airborne transmission risk in the general hospital than in the hospital which is implementing the airborne infections. So in this picture, you can see that the relative risk of TB is 6 times higher than in the hospital, which actually admits only TB, but implements the airborne infection control measures hierarchy, as was demonstrated. It means the theory and practice works. It's extremely effective, and we are able to reduce risk or eliminate even risk to zero. So who are the potential high-risk airborne transmitters? So first of all, like in TB, all undetected, undiagnosed coughing patients. Cough increase the concentration and intensity of the generation of aerosol. And we know now that some COVID patients, they are asymptomatic or oligosymptomatic. It's the same about TB. So it's the same about every airborne infection. So they actually transmit most of the airborne infection, undetected, undiagnosed ones. So respiratory patients, we do not receive effective treatment. Effective treatment is available for TB, as I said. It's not available for many others and other viral infections, unfortunately. But for TB, it can happen that the treatment is delayed, interrupted, or defaulted. The ineffective treatment regimen used, ineffective means not based on the drug susceptibility testing of MTB. And for TB, most sensitive and available contagiousness indicator is sputum smear microscopy before effective treatment initiation. For COVID, we do understand it's positive PCR result in the beginning of the disease. PCR became not informative about the contagiousness after 7-10 days. It's not an indicator anymore, like smear is not, or culture is not indicator of infectiousness after the first days or at least weeks for drug-resistant TB of effective treatment. So these are criteria which can help us to organize the risk assessment of the facilities. The one slide about the effectiveness of the treatment on the contagiousness of TB patients, and that's based on actually the study published in 1976 by Dr. Rui Long, and she worked for the International Union against TB and lung disease, and she studied the transmission of TB, actually skin test conversion rates among the family members of TB cases in India. And she found that the transmission of TB or conversion of the skin tests occurs only before the initiation of the treatment. As soon as the treatment was initiated on outpatient basis, so patients remain in families, but the transmission stops at that time. So it was later confirmed for drug-resistant TB, and the classical study about airborne transmission by Riley and Wells, the Boston specialists, Harvard University specialists, they found that the TB is transmitted through the airborne route, and also that they found that the UVGI is very effective in terms of disinfection of the air. It stops transmission. And also they found that there's a striking effect of the effective therapy on the contagiousness of the patients and on the transmission of TB. And this is actually the basis for the most effective intervention in the administrative control. So it's about the prompt initiation of the effective treatment of the patient. So we need rapid testing for that, and we need drugs, and we have to use drug susceptibility testing for the designing of the treatment regimen for each individual, each patient. These graphics show the impact of the reduction of the diameter or radius of the particles exhaled by the patients, and with the reduction of the diameter or radius because of the drying of the liquid from the particles. So the volume of the particles is being reduced very sharply, tens and thousands even times in a few seconds, and the concentration of the drugs in the these particles, which contain viable mycobacteria or other pathogen, the concentration of the drugs is being increased with the reduction of the diameter. So these drugs, they're effective in the body liquids, and they are super effective in the inside the particles. And because of that, actually the phenomenon of the sterilization of the aerosol takes place, and transmission is being stopped effectively by effective treatment. So this is actually the basis of the FAST strategy introduced and actually developed by Dr. Nardell from Harvard University. Ed Nardell will be presenting in next webinars. And it's FAST is about the finding cases actively by surveillance and rapid molecular sputum testing, separating them based on the case finding, and effective treatment, prompt effective treatment based on the DST. So is it applicable for all the airborne infections? I would say at least partially yes, for sure. We have to find cases of any airborne infection and separate. Treatment, as I said, not always available for all airborne infection, but separation and isolation works in terms of reduction of the airborne transmission risk. The rapid testing for SARS-CoV-2 is already available. There are tests, they are more expensive than conventional PCR, but CFID now and Global Fund that supports the delivery of these cartridges for GenExpert machines. So this is extremely sensitive and very specific test for COVID, and it helps identify the cases, most contagious cases, and to provide prompt isolation, separation, and treatment as well. So we in Vladimir, we validated this test and use it for rapid actions during the admission of the patients. So in conclusion, I would like to say that the considerable portion of airborne infections transmission takes place from undetected, undiagnosed patients, and was proven for COVID, as for TB. We see, and the aggressiveness of the transmission of the COVID epidemic is maybe explained by both this silent transmission and also airborne transmission. So no borders work against the COVID because of these specifics. Case finding with rapid testing to identify airborne pathogens, and if possible, to identify the drug susceptibility should be the first priority, and it helps to provide better care, but first of all, to reduce the risk. We have to, based on the results of this rapid testing, organize prompt and effective airborne isolation. We have to initiate effective therapy rapidly and to stop transmission for TB at least, and hopefully for other infections. So in conclusion also, I would like to repeat the sorry, one more slide here. Yeah, the list of the all most important administrative measures is presented here, and I would say the most important intervention in terms of administrative measures is education and training, and education not only for healthcare workers, not only for healthcare providers, but also for policymakers, for all the patients, staff, family members, all the population. So the people should understand the route of transmission specifics and the complex of measure dedicated to reduce the risk. So we have to educate them on correct use of PPE. They understand the principles of the airborne infection control hierarchy, and they have to understand the organizational issues related to each intervention in the hierarchy. We have to provide active screening for all patients. It's also a very effective administrative measure. We have to screen not only patients, but also all staff members with this COVID. In my hospital, we start the day from the temperature measurements and symptom screening. And again, and just share my experience in my hospital, we do have several cases of COVID among staff, and 0 cases transmitted to the patients. So the transmission is stopped, and the patient floors where all the complex of the measures implemented. But with staff who bring actually infection from families, from public transportation, it happens, it occurs, and in the low risk areas without PPE, there is some transmission between staff members. Fortunately, it doesn't occur in the patient floors. So the airborne measures, they're extremely effective, not only for TB prevention, but also for COVID, which is very aggressively transmitted. We know about that. Airborne transmission risk assessment is a basis of all the other interventions. We have to understand where, why, which procedures, which patients, which visitors pose the risk. And we have to organize zoning, divide the facilities into high, medium, and low risk zones and separate them, and organize safe flows of patients, staff, visitors, and so on. Use of surgical masks or wearless respirators for all. For TB, we do require the respirators. They can be used with valve, but for COVID pandemic, the waveless respirators are preferable. They stop the exhalation of into the environment of the aerosol from the healthcare worker, which can be also the patient. And the surgical masks are for all. They are not as effective as respirators, but they are much cheaper and much more affordable and feasible to implement. Separation of patients and visitor and staff flows. Again, airborne separation, airborne isolation will be discussed later. We have to revise design hospitalization criteria based on the severity of cases, but first of all, based on the contagiousness of patients. We have to have criteria for that. We do have criteria for TB, and again, before initiation of treatment, it's smear. First of all, after the initiation of treatment for TB patient, the contagiousness of patients stops almost immediately. We have to reconstruct and restructure healthcare facility based on the airborne infection control principles. I hope that humanity will learn from this pandemic very bitter lesson that healthcare facilities should be safe. We have to think not about the contact infections or just regular disease, internal disease or surgical disease. We have to think about airborne transmission. And in my understanding, this is not the last pandemic of airborne infection. So we have to be prepared, and it should be included into the norms in the countries and international norms about safe design and safe systems implemented in healthcare settings. We have to use rational, affordable, feasible diagnostic and treatment algorithms, including rapid molecular testing for airborne infections, and they are available now. And the immediate initiation of airborne isolation effective therapy based on rapid testing and DST results is an extremely important administrative measure. So again, I would like to refer you to the web page of ETTI. There are resources published in several languages: Chinese, English, French, Spanish, Russian, and you can find webinars, you can find short information lists, pages on different components of the hierarchy. This is all from my side, and I would like to again remind you that we have to think about safe air around, and we have to share the knowledge, the skills with all healthcare workers involved into the fight with the COVID pandemic in our countries. Thank you.
Thank you, Grigory. So I suggest we take the questions at the end of the 3 presentations. Is that okay, Grigory?
Yes, absolutely. Thank you.
Okay, great. I see that there is some exchange already happening in the chat function, which is very great. I think we should use that chat function as much as possible. And we will also collate from that chat some questions to be discussed at the end. So the next one is the South Africa experience. Dr. Mache, over to you. Please go ahead.
Thank you, sir. Good afternoon, evening, and morning to everyone. This presentation gives an overview of TB administrative control measures implemented in South Africa that can be leveraged in response to COVID-19. So I will give a brief background on different strategies to reduce the spread of COVID, share examples of how the administrative control measures, including FAST that has already been mentioned by Gregory, how that has been implemented in South Africa in response to COVID and its successes, and also touch on IPC at household level, highlighting TB and COVID community screening, and also share lessons learned in general. So COVID pandemic has affected South Africa. TB case notification has gone down. Average weekly gene expect testing has decreased by 48%. Weekly number of persons tested positive has declined by 33%. And this is not due to lack of lab capacity, but also as a result of limited movement during lockdown, and thereby access to services was restricted. Also, there was no transport available. So as we continue to roll out screening for COVID, let's not neglect TB. TB has so much to teach us about the tools. There are existing skills and knowledge that can help us mitigate the current pandemic. That also includes the importance of infection control, the issues that we are discussing today, active surveillance, triaging in the healthcare setting, cough etiquette, rapid testing, diagnosis using a rapid test, isolation, treatment, contact tracing, and public awareness. Also, not to forget the importance of community participation and other congregate settings for awareness raising and prevention and early notification in COVID. Also important is collaboration of national prevention programs, HIV and non-communicable diseases, to improve prevention and also detection of other diseases. So in the next few slides, I will be sharing some examples from South Africa, what we have done. There's a lot of emphasis on the importance of risk assessment. Gregory has touched on it, to identify specific problems that may expose someone to TB or Sorry, Gregory, you can mute yourself. Okay, yes, so the infection prevention control measures and the resources that should be put in place should be informed by the risk assessment. So we've conducted risk assessment to evaluate preparedness, prevention, and control of COVID in facilities. We currently do not have a standard tool that includes both COVID and TB. However, provinces have been proactive and came up with a tool that has both. So the tool is looks at the state of IPC compliance, which is reported in the form of a dashboard, what is in place, what is partially done, and what is not in place. And thereafter, facilities develop integrated IPC plans and also SOPs. And also important is development of quality improvement plans, to ensure that minimum requirements are met. And also this is reviewed by the rapid response teams or task teams weekly to monitor progress. So this is an example of existing mHealth technology that can be used in the fight against COVID to monitor IPC compliance. IP Connect is a digital app with a platform, among others, that are there. We have a platform for TB risk assessments. It is zero rated, which means it is free. Dashboard is available. You are able to get the results immediately, print the reports, and it will flag areas that need follow-up. The bottom right of the screen is an example of how we report or track performance over time. And this is an example of facilities somewhere in the Western Cape. I've just selected 2 indicators, but what I'm highlighting here is the importance of tracking progress over time and giving feedback to the facilities as it motivates people and boosts their performance. So 2018, you will see, which is blue, the word 66, 65, and a year later that improved to 89. And then same applies with availability of IPC guidelines, as 60% of those facilities did not have, and that improved later on the following year. So it is one of those digital technologies that can be used as well, even for COVID. Grigory mentioned the importance of education. So this slide highlights exactly that, the importance of training our staff on new knowledge, available guidelines, updated information, monitoring of adherence, which is mainly important in order to achieve a successful implementation. He mentioned the importance of not only training healthcare workers, but also patients. You know, under healthcare workers, that would also include community care workers, be it you train them on COVID, TB, IPC, and screening. That is very important. What is also important as we train them on IPC is the importance of fit testing for respirators, which is important for both TB and COVID to ensure that the respirator fits and seals properly to, so contaminated air cannot leak into the respirator. I've just shared some examples there where we train key personnel that would be able to fit test other colleagues. And also in the middle, we have a picture there showing how you disinfect the hood. And on the far right, we have somebody who is doing cell check. We have also developed a supportive culture, which was mentioned in the previous webinars. Paul spoke about it, a buddy initiative, you know, where if you notice someone hasn't worn PPE properly, we often come across in the facilities or even in the community. We need to point out to that person without embarrassing them. It means a lot, and it will save many lives. So in terms of you know, respiratory protection, it has been difficult during COVID. With fit testing, healthcare workers have had concerns about the hood getting contaminated and you know, what should be done in that case. Of course, we do disinfect using that 70% alcohol, but added to that, you know, facilities have come up with plans to say, rather than fit testing people a high number of healthcare workers within short space of time or within a day. Let's rather stagger that throughout the week. You can either field test one person and then you decontaminate your hood, aerate it overnight, and then do the same the following day. So that seems to be working, and we continue conducting field testing. South Africa is implementing FAST strategy. Gregory touched on it, the basic principle behind FAST, which is about finding cases actively, separating safely, and treating effectively. So this is an administrative control strategy that is aimed at enhancing infection control measures and strengthening TB services in health facilities. So the same principles are currently being used to tackle COVID in the country. In South Africa, we are implementing FAST in 86 out of 102 hospitals that have been identified. So the general approach is TB screening of hospitalized patients, diagnosis, which is supported by rapid molecular drug susceptibility testing using GeneXpect, and also making sure that once you have identified those patients, you put them on treatment. It is implemented as a package. It is integrated with LF-LAM and also with CQI, which is continuous quality improvement methodology to address the gaps that are identified during implementation. One of the successes is detection of unsuspected cases in areas where you would not ordinarily screen for TB. So we are finding cases in those areas. And I think the key message here is that the administrative measures should be put in place to limit transmission of both TB and COVID. And then here's an example of how screening is done where FAST is implemented in response to COVID. Queues are managed from the gate using the zoning criteria, and also to address patient flows to avoid mixing of symptomatic patients with vulnerable patients. So we have a standardized triage algorithm and a questionnaire to determine the priority of these patients, and of course that zoning criteria where you will say this is high risk, moderate risk, and low risk. At the bottom on the left side is an example of what has been happening even before COVID. This is the first side. So what we're seeing there, the person wearing kind of yellowish jacket is security personnel in one of the first sides. So what they would do as pedestrians walk through the gate, they would identify patients that are coughing and would provide them with a surgical mask and direct them to an area where they are supposed to be screened. So that has been happening. And of course, we also observe social distancing. And, temperature is also taken in those areas. This is an example of an integrated screening tool used for screening for TB and COVID. And on the right, we have an app that can be downloaded on the phone. And there's also a web-based app. So the report gets submitted to a central area through the app, and the results are communicated to the user and also to the district that are supposed to dispatch a team for contact tracing. So patients that are symptomatic for other conditions as well are flagged for further investigation. So that app is currently in place in Gauteng province. So in terms of testing for TB in hospitals, the laboratory network system is well established. A high number of hospitals have labs with GeneXpect on site. I would say around about 90% of the hospitals. However, when it comes to COVID, not all hospitals are testing sites. So all facilities will do the swabbing for COVID, but only a dedicated hospital labs can test for COVID. We also have an effective transport network system. There is a courier system to transport specimens, be it at the swabs or be it sputum that needs to be transported to a lab for testing. And there's also a clear referral pathway for screening, swabbing, and also testing. In terms of separating safely, Gregory mentioned the importance of infrastructure, making sure that we have well-ventilated areas and so forth. But what also important while we are separating physically is to educate patients on respiratory hygiene, cough etiquette and separation, and also counseling patients. There's a stigma associated to COVID and also TB. So patients get moved to a well-ventilated area, and then for people under investigation, of course, if there's no way that they can go back or you do not want to lose them, then they are quarantined in the wards to prevent further spread. So on this slide, I'm just showing the benefits of implementing FAST as an administrative control strategy. We've seen some reduction in terms of the turnaround time and also reduction in terms of loss to follow up and also treatment delays. We have seen a decrease from 4.3 to 1 day from time the sputum is collected to treatment. And we've also seen some reduction from diagnosis to treatment from 3.5 days to 0.5. And also in terms of the proportion of patients that have been put on treatment, that has increased from 61% to 100% for patients that are treated within 2 or even fewer days. So that's one of the benefits that we have seen through FAST. This slide highlights the importance of actively screening in all units within the facility. Screening in all entry points, even though at times, in hospitals, there will be one main entry point, but there are always leakages depending on the condition of the patient on admission. So what we are finding is these unsuspected cases in the wards that admit key populations. And these are patients that you would not ordinarily screen for TB. And some of them are, are patients that are also at risk for COVID. An example there, we are seeing a high number of TB patients in the ARV unit and also the isolation unit. And we also screen healthcare workers in the facilities for TB, and they're also being screened for COVID. But data presented here is unsuspected TB cases in those key areas. And this slide highlights the importance of maintaining TB services as well for immunocompromised people who are at risk for COVID. As I've mentioned earlier, that FAST is implemented as a package. We have LFM and CQI. So in terms of LAM, we have seen a threefold increase in terms of case detection in patients within these hospitals. So it is also important that we screen for TB and also COVID among patients with compromised system. And then the next few slides, examples from the community. These are examples from screening door-to-door campaigns in the community. It highlights the work that is done by the NGO. An example here is just 2 NGOs within a month where they had tested about 30,000 plus people with COVID. And out of those, 66 of them were symptomatic for TB, and 3 of them tested positive and were put on treatment. So that is a success. We are able, if we continue to screen for TB as well as we roll out screening for COVID, we will continue finding these cases. We also conduct household risk assessment with the aim of looking at IPC compliance and people with vulnerabilities in the homes. This is done through the NGOs mainly, looking at who are doing contact screening, who will refer symptomatic patients to clinic, will provide counseling, and what is also important is to educate patients on IPC, TB, and also COVID. There are challenges though, because most of these places are in informal settlements, and there are serious challenges when it comes to environmental issues. There's overcrowding in these households. Ventilation is an issue. Some do not even have windows. And at times you will find that in that household, there are children under 5 and also patients living with HIV positive people. And also, at times there are people who live with people who are smoking and also abusing alcohol. However, there are also successes. We'll continue to educate them on IPC, TB, and also COVID, and also raising awareness and emphasizing reducing that close contact between children and adults. And what is also what has been a success is a collaboration with other sectors, social services, where we refer those people with alcohol abuse problems. This is another success story from First Sight, where 27 patients that were referred by an NGO were admitted, were tested for COVID and found to be negative. However, 4 of them were found to have TB and were all linked to care and put on treatment. So it also emphasizes the importance of collaboration between the community or NGOs and the facilities. And also, the 2 programs, TB and the other programs. In terms of lessons learned, political will is key. We need buy-in from higher management, supported national, provincial, district, and also facility level from our CEOs, so that there's better cooperation from the implementers. And also it is also important to empower healthcare workers so that they can take the lead. And also, peer learning sessions are important, learning from each other so that they can improve on the task at hand, and also to motivate and also for them to gain confidence. Lessons learned is improvement in terms of turnaround time that I've also alluded to, be it from sputum collection to treatment or diagnosis to treatment, that has improved a lot. And also identifying TB among patients with HIV. We are finding those cases, and also strengthening surveillance among healthcare workers, and the integration with CQI, where we address whatever issues that have been identified. And continuous monitoring of IPC activities has improved. We have indicators that facilities report on every month. And in terms of challenges, infrastructure is a problem. And here and there will always be that lack of commitment. Healthcare workers need to be motivated. And one of the challenges with regards to LFLM has been that it is mainly doctor-driven. So that has led to treatment delays. And that is all from my side. And I would like to thank the Department of Health, provincial departments, and also the facilities that have supported this initiative, and also USAID for funding the project. And that is the last one. Thank you.
Thank you, Metsi. We now go to the next one from China. Over to Dr. Liu Yuhong.
Thank you. Can you, Masi, can you close the screen sharing?
Okay, I will do that.
You will find it on the top of your screen of the computer. Stop sharing.
Yes. Okay. Should be fine. Thanks.
Yes, go ahead. We can see the slides.
Okay, thank you very much for giving me the opportunity to share some of the experience in China, specifically what we have done in my hospital in Beijing Chest Hospital to respond to COVID-19. First slide as a background, you may, everybody knows that the first case was reported in early January in China, and it is rapidly, the number of the cases rapidly increased in February and in March, and also rapidly spread all over the China, most area of China. But the number of the cases was decreased after March. So up to now, we have a total number of confirmed cases like 85,000 and about 4,800 deaths. After the outbreak, I think the Chinese government took very strong measures to fighting against COVID-19. Not only health system, but also the whole country, the entire system is in action. So in terms of the health system, what we have done is mainly rely on our existing health system, including CDC, hospital, and community. The different departments have different different responsibility. CDC are responsible for data, for epidemiological survey, for the education and guidance, guideline development, something like that. Of course, hospitals are responsible for diagnosis and treatment. Also, they have very strong community. Their responsibility is mainly focused on contact tracing, contact management, and isolation the patients in risk, and also active screening. This is how the health system run. So today, my topic will focus on the hospital, how our TB hospital and the COVID-19 designated hospital, what we have done in terms of administrative control. So what we have done for administrative control, we have upgraded our infection control and prevention regulations, documents, and the requirements. And also we trained our medical staffs. Also we took different measures to minimize or stop transmission in the hospitals and other facilities. So I will explain it in detail. In terms of the document and the regulations, so after the outbreak, the national authority and also our local authority, like Beijing City, the government and the technical authority issued a lot of documents or upgraded a lot of documents. Here, the photo just to show you some of the upgraded documents developed in my hospital. So I remember in my hospital from January to up to now, we have issued more than 100 documents. Some of the documents is on infection prevention and control. But of course, infection control is not something new in my hospital. But for the COVID-19, with the COVID-19 coming, so we have to tailor our current existing measures to the needs of COVID response. And also we translated a lot of international material like what showed here. We translated ETTI information sheet, not only for the use of inside our hospital, but also we disseminate all this material to other hospitals in China, not only TB, but also not only in TB hospital, but also other general hospitals. Also, we have developed several material for patients, not only for patients and for the patients' family members, how to guide them, how to use the different masks. Here I would like to mention some of the training because after the outbreak, the training on COVID-19, including infection prevention and control, become a mandatory training for all healthcare workers. Here, just to take example, in Beijing City, we have this Beijing Continuation Medical Education Platform. We use this e-learning module, e-learning platform to learn the new guidelines and the new requirement. Here with the red circle, I just mark the list of the request courses based on COVID-19. After you learn the video, you watch the video, you have to pass the examination to pass the test. This is mandatory for all health workers. Without learning this, without passing the examination, you cannot get a kind of promotion for the coming year. So everybody has to learn that. This is just one example for training. Also, we take a lot of administrative measures to minimize the transmission in the hospital. So this slide just to show you in different hospitals, how the patients and what kind of patients are gathering in different hospitals and what is a patient flow. In the middle, you can see we have a designated hospital for COVID-19. All the cities, all the places, they have the health authority designated several hospitals for COVID-19 treatment. For example, in Beijing, we have 18 designated hospitals for COVID-19. But you know, in Beijing, the total number of hospitals is like 3,000, something like that. But the city government just nominate 18 hospitals who have a good capacity, who have a good condition for the infection prevention and control to become a designated hospital for COVID-19. But this hospital, designated hospital, only treat the severe cases. For those mild cases, they are because they do not need, they really need the intensive care, the intensive treatment. So they they are treated in the mobile cabin hospitals, because at the early stage, there are a lot of patients. They cannot, only the designated hospital cannot meet the requirement. So you may know from the news, we have established the new mobile cabin hospitals using the the support studios, using the conventional centers, just after some motivation to become the mobile cabin hospital to provide the mild patients with the basic health service. So another in the top, you can see that the orange one is a screening hospital. Those hospitals, they are not treating COVID-19 patients, but they do screening, primary screening. If the patients are confirmed as COVID-19 patients, so they can be referred to either designated hospital or mobile cabin hospital. And also you can see the green one is the isolation center. This normally in the community level or the county level. This is for those patients, for those people who are at risk, for example, the close contact with the confirmed patients. They do not have maybe symptom, they do not have fever, they do not have positive NAT, so, but they are in the high risk, so they isolate them in a isolation center. Normally this is based on a hotel or something like that. So by doing this, first we can optimize the health resources. Not all people just gathering in a big hospital. They can optimize the resources in one hand. And in the other hand, by doing this, we can separate patients at a different risk, at a different level. So if we go into the detail about each level hospital, we can find that because the responsibility of each hospital is different. So the patient there are actually a little bit different. For example, for the screening hospital, most of the patients here actually are non-COVID-19 patients. Sometimes it's also including some patients and some other disease, some patients with other diseases. And also some patients who have symptom, maybe fever, so they actively seek for screening whether or not I have COVID-19, so they come to the screening hospital for active testing. This is population here in screening hospital. But for the mobile cabin hospital, all of them actually are confirmed COVID-19 patients, and some of them, not much, are highly suspected for COVID-19 because they are not really get a final confirmation, but they highly suspected and need medical care. They cannot go into the designated hospital, so they just stay here, stay in the mobile cabin hospital for treatment. And also, the COVID-19 designated hospital, most of them are confirmed patients, but also there are, because this designated hospital, also the general hospital, there are a lot of other patients coming, including TB, or sometimes some other patients are not TB. So you can see the combination of the patients and the people coming into different hospitals are actually different. So the administrative measures actually based on early identify and early separate this patient at a different risk. So I will give you some of the example in what is doing in my hospital, Beijing Chest. So before that, I will give you a very short introduction. Our hospital is a grade 3A hospital. So we have TB and lung cancer. We are actually is a specialized hospital. And we have a total 612 beds, 300, including 300 for TB. And also we have a research institute. We conduct TB research and also the research on lung cancer. Also we have we have a national role as a National Clinical Center on Tuberculosis. We support NTP from the clinical aspect. This is just overview of introduction of my hospital. So in COVID-19, our hospital served as a screening hospital. So I just give you some of the photos to let you know what we are doing here. So actually the first step, the primary screening, is happened in the main entrance of our hospital. So what we do here is we do temperature. We monitor the temperature to everybody who coming into our hospital, including the patients, including the patient's family members, and also the health care workers. So we use temperature and also asking the symptom, whether you have some coughing and whether you have fever, something like that. This number one. And second, we use this health QR. Health QR means quick response, health quick response code. You can use your, so everybody normally use, we have the cell phone. We use our cell phone to scan this, this code. And if the code, if your mobile shows the green color, and also indicating everything normal, no abnormal, meaning that you have not any exposure to high risk area in recent 14 days. You know, in China, we have, because the government identify certain area like which city, which county, which district as a high risk area, middle risk area, and the low risk area. If your code shows green, meaning that you have never been to the high risk area, never been to the middle risk area, you just stay in low risk area. So this is by doing this two primary screening, we can identify people into low risk and high risk, these two groups. So for those who have a different, have an abnormal temperature or have abnormal health quick response code status, they are guided to a favor clinic for the further screening. Of course, the healthcare workers, every day they come into our hospital, they have to go through a separate entrance and also do this, the temperature screening. Also, our hospital set up a newly set up a favor clinic for the secondary screening. So in the main entrance, once the patient have any abnormal, so they can be sent here for the further screening. The favor clinic is a separate building far from our main hospital building, and there are several beds. In the beginning, there are like 8 beds for patients waiting for result, because some of the patients cannot get the result immediately, so they have to wait for maybe overnight, maybe 2 or 3 days, and later we have more number of the beds. Is now right now we have 16, and here in the favor clinic, all the healthcare workers are fully equipped with PPE. What the patient then would receive here, they need to do some confirmation test at the favor clinic, including they have to be repeated their body temperature and do the nucleic acid test and also epidemiological survey. These 3 items is something must in the beginning, and now maybe after, I remember it's after April or May, so we also include the chest, the CT scan, and antibody test and the blood routine include. So right now, so all the patients, if have any abnormal and transfer to the favor clinic, they have been done this 6 items. And for the patient with a normal meaning they do not have fever, they do not have any abnormal on the cold chesting. They can refer to the normal OPD for the ordinary diagnosis and treatment. So here is our outpatient department, so that you can see the patients are requested to keep the distance at least 1 meter from each other. So normally in the past in our hospital is because we have a lot of people come in every day, and normally the social distance cannot really strictly followed. So but after outbreak we have you can see there's a doctor, is a healthcare workers here to maintain the distance, and the patients also is willing to keep this distance. And also we separate our seats in our waiting area. So you can see we covered the middle seats with some film, and patient can just sit in the outside these two seats. So by doing this, the patient can be separate each other. Another way what we do is to minimize the number of the normal TB patient, meaning minimize the number of the follow-up paid visits to the hospital. Because I mentioned our hospital, 50% of our patients are actually TB patients. They have to come to hospital for follow-up test and also take medicines. But we use this kind of online consultation system and this kind of digital medicine platform to help the patients to give them education and a consultation. And also we can prescribe, the doctor can prescribe TB drugs through this app and deliver the drugs to the patient. So that the patient do not really unnecessarily come to our hospital every month to take their drugs. So in summary, in our hospital, we have a primary screening at the hospital entrance. We do the body temperature screening, symptom asking, and also check the health code. And by doing this, we separate with a red group and a green group, which is normal. At a normal outpatient department, we do different approaches to separate the patients as much as possible and to protect the healthcare workers as much as possible. At the red color part, so very strict infection prevention and control measures are taken, including top level PPE. And also here, the patient can get the prioritized testing, meaning that they can get rapidly testing for the nucleic acid testing and others like CT scanning. They do not need to wait. And also we use the separate ward for different patients. They can wait in a single room, do not have any contact with other patients. So by doing this, the goal, the objective is to early identify the patient, early diagnose the patient, and early refer those patients to the designated hospital. What we have learned from TB hospital in terms of infection control for COVID-19, I think because in the very beginning, COVID-19 is very new to everybody. We do not really understand what is COVID-19. So, but I think that, but I think the hospital really benefit a lot from the from what TB hospital doing, because they are sharing the same principle on infection control and prevention. Because we our COVID-19 hospital, designated hospital, some of them are TB hospital as well. Some of actually general hospital, they do not treat TB. Because TB hospital has a more experience on working with communicable disease, especially respiratory non-communicable disease. So the doctors and the nurses have a great sense on infection control, has more experience and skill on infection control. So compared to general hospital, the TB, the healthcare workers working at a TB hospital has less infection of COVID-19. And also, I think COVID-19 hospital, they learned a lot from TB hospital. Especially on the infection control. But in the beginning, because everybody do not really know what is COVID-19, but they just give more attention on infection control and share some learn experience from TB part. So I think it's something good for the COVID-19 and learn from TB. And in terms of license learned, I think because IPC is normally is a routine practice in practice, but it still need to be emphasized as a daily routine. Some of the requirement or some of the practice are not really strictly followed in the practice. Only when something, the outbreak come in, so everybody just thinks IPC is really important. But after this outbreak, so the hospital doctors and all the health workers, they really understand how important IPC is. And also the doctors and the nurses should be regularly trained and refreshed, trained on infection control and prevention, especially for those departments who are dealing with non-communicable disease hospital, because we have found, because according to the report, the doctors and the nurses infected with COVID-19, especially in the very beginning, most of them are actually working at a non-communicable disease department. And also, so the third one is, I think, hospital, they should normally regularly have a basic preparation for the prevention and control. Especially, they have to prepare some personal protective equipment, and also train the people, doctors, how to use this PPE, and also need to have a backup plan for the potential outbreak. I think this is something I would like to share with you. And this is my last slide. Yes, this is drawn by my daughter, which is a middle school student in Beijing. I just want to use this picture to close my talk. Really wish all of our doctors and our nurses and the healthcare workers can well protect ourselves and stay safe. Thank you very much.
Thank you, Leo. So now we open this for discussion. I hope the speakers can remain with us for some time. Is that correct, Gregory, Matsi, and Leo?
Yes.
Yes.
Great. So I see two questions already on the chat. Basir, so instead of reading out, maybe you can ask the question yourself. Basir, go ahead. From BRAC. Maybe you're not muted, but let me read the question that Basir is asking. Have you detected any TB even after coming for COVID test and CT scan? I'm not sure for whom this question was.
Have you detected?
There were some questions on co-infection. So is it related to that or something else? Basir, can you tell us?
Thank you so much. I'm question to Linchin. That is, they have the CT scan doing in their hospitals. So after that, they will get any TB patient after CT scan or COVID test. That is my question. You got the point?
Yes, Liu, do you want to respond to that? Or anybody else wants to respond? Or
Yeah, hi.
Liu, I think, yes, go ahead, Liu.
Yeah, this is Yu Hong. I think in China, because most of the COVID hospital and TB hospital are actually separate. Of course, by doing a CT scan, we can, if the patient experience, we can find some TB. But when the patient coming for COVID test, they do not normally do TB specific testing, like a culture, like a PCR, something like that for TB. No, it's not our routine practice. But from CT scan, if the doctor have some experience, they can find some TB. But in general, the TB hospital and the COVID hospital are separate. It's not in same hospital.
Thank you. And now the second question is from Amy Bloom. Do you want to ask the question? Amy, you are muted.
Is that okay now? Because I'm trying
Yes,
to.
go ahead.
Okay, great. Thank you for great presentations. I was wondering, in the slide that you had on the Red Fever Clinic about the strict PPE measures, were those strictly just for the staff or for patients as well? I'm thinking of this partly because I know of some people who have had medical issues that cause them to have high fevers and all, but they've been afraid to go to the clinic. And then when they've gone, or to the ER, when they've gone, they've just been put in places with people with COVID, and they don't have COVID. They have other issues that cause that. Thank you.
Okay, thank you for your question. I think the question is to me. The first part of your question in the Red Fever Clinic. So the very strict PPE is for the healthcare workers, meaning they need to wear the N95 mask and also the eye cover, the shoes cover, the protective gowns. Something like that. But for the patient, we only request the patient wear masks. Some patients using N95 and some patients are using just the surgery mask. Because the patient are isolated into a separate room, they are not stay in the same room. So for the very strict PPE is only for the staff. And I think the second part question for the patient with no health issues. Yeah, this is a problem because of the outbreak. The patients, they are hesitant to come to the hospital for the medical care. This is normally often happen. We can see that those kind of situation. And the patient, if they can get some like a basic drug, basic health care in the community, they do not come into the hospital. And also in some places, because the community are actually closed, the people cannot go outside the community. It's very strict follow. They have to strictly follow the close management of the community. But for the patient already have some known disease, they can use the like a mobile PP apps, or they can use the distance consultation system to get the online education consultation. And also we can prescribe the drugs for the patient online and deliver the drug to the patients. Did I answer your question?
Yes, thank you. I guess just to be clear, I was thinking, I will give you a situation. Someone has a known illness that has episodic, that comes up episodically, causing high fevers. So when they present to the hospital, they are often then assumed, given the situation, that they have COVID. However, you can't just treat them until you see them. You can't just put it in. So I think you've answered the question. If they're in a separate room, then because they are then at risk for getting something on top of it, is what I was thinking. But thank you. Yes, you did.
Thank you. This kind of patient, they need to do the COVID test first, and if everything negative, so they can get the normal diagnosis and treatment for other diseases.
Yes, I think there is also a related question from Paul Jensen. Paul, you will also need to contribute to answer this because you say it is difficult. So what is the sensitivity and specificity of fever as an indicator of COVID? Because of all these issues about asymptomatic cases or oligosymptomatic cases. So this is an issue. I don't think people have a straightforward answer to that, but Paul, do you want to comment on it?
No,
I would like.
Yeah, I'm just asking for the people's experience in dealing with that issue. Thank you.
Gregory wants to comment. Yes, go ahead.
Paul well knows that there is no golden bullet to reduce the transmission risk to zero. If we would have such bullet, we would forget about everything and just use it. But we have to use all available tools. If we screen for temperature, we reduce the risk for a certain percent. Masks reduce risk for 50% in the room. So on some patients are oligosymptomatic or symptomatics. So this is the danger. Again, we have to do what we can do, what is feasible, what's affordable in our capacity to do. So in my position in my hospital, we just inform all staff members to stay at home if they have any kind of suspicious symptoms like fever, like losing sense of smell, and anosmia or weakness. They can stay at home 1-2 days. We do not punish them. They get tested, and we allow them to return back to work when the test is negative and no symptoms occur. So no golden bullet, but we have to do what can be done in this situation.
Thank you, Gregory. Any further questions from anybody? I see some comments there. Godwin, do you want to say something? You said online patient consultation is a nice touch to minimize hospital visits. Are there any questions?
Yes.
As a comment?
Well, thank you so much for the presentation. It's more like a reaction here. In Nigeria, we have limited facilities for online consultation. There are hospitals that are set up using electronic medical health systems, but most of them are running locally within the hospital. So if you are not within the hospital, you cannot interact with the system. So it's a challenge. And stigmatization of COVID-19 patients is not helping matters. People don't want to be linked with it. When they have fevers, sometimes they stay away from the hospital. And sometimes when they come, they give you histories that would mislead you into making a wrong diagnosis, especially if they are asymptomatic or oligosymptomatic. So I think the online consultation is something that we here in Nigeria would want to really try to kick off. There are movements to go into that because a lot of people are in hard to reach areas and data is very much affordable and available now. And with that, they should be able to access some basic care without having to come and queue up somewhere or not even coming to hospital at all. So I think it's something we need to do over here to help ourselves. Thank you so much.
There are a number of questions coming, so maybe Jimoy, would you like to ask the question?
Yeah, thank you. You know, tuberculosis has been with us from time immemorial. I remember I used to report the TB program as way back as 1992 and the late 80s. And what benefit do you see that the COVID-19 pandemic will provide for COVID-19? Because COVID-19 will go but TB is likely to remain with us. So what are the lessons learned now that we can apply to our TB response, as we move on from this pandemic? I just want you to be futuristic.
Good. So let's keep the discussion focused on what lessons in the context of infection control we learn and how it benefits TB. So any comments on that from the speakers?
Thanks.
Anything from the speakers? Maybe I can start some things and maybe others can also add if they want. I think this is a great question. It is not just that we experience the COVID pandemic. I don't know how long it stays, maybe till we have the vaccine or so on. But we have to learn from that pandemic. I think one important thing that has happened and which TB will benefit is infection control was very much in the periphery of the health system. Only a few people were engaged in infection control. I remember the group that dealt with even TB infection control was very small, and over the years has remained like that in terms of expertise. And I think what COVID has done now has put infection control in the mainstream of airborne infection control, in the mainstream of the health system, and how health systems should be addressing this issue. So I think that's a big opportunity for TB to then ensure that the entire health system, including TB, the part that deals with TB, drug resistant TB, benefits out of it. So I see that there will be, hopefully, more commitment, more funding, and more opportunity to do in the TB world what we wanted to do in infection control because of COVID. I think that's a big advantage I see. I allow other people to speak on this if there is anything else.
This is Marcia, yes. I just want to add something. The importance of infection control also in non-clinical settings. We tend to focus in clinical settings, but an example like in South Africa, it is a legal requirement that risk assessments should be conducted. You identify the gaps so that whatever measures that you put in place are informed by that risk assessments. So, the very same practices that are implemented in facilities, now organization or employers are expected to do that. So, yeah.
Yeah, thank you for...
after COVID, we'll continue doing that.
Thank you. And I would also say the general people have got educated about masks, about cough etiquette, which will also help in the long run for TB. I see some more questions there. If funds are available, would you recommend COVID-19 screening for all TB suspects, PCR or expert? This is from Predrag. Does anybody want to answer that question? I would answer with a yes. If funding is available, we should recommend COVID-19 screening for all symptomatics because symptoms are similar. Actually, we did estimate at what would this mean if you test everybody with a COVID test prior to getting a TB test, which takes away the fear also of handling sputum and handling the patient. So this is something which will be a big amount of money, but looking at the commitments and pledges being made for COVID response globally, I think it is something that is feasible. So I wouldn't say if available, I would say we should demand for it and get the funding for doing it. Any other responses to this?
I agree, Sahu. I think testing is the key in all the intervention, treatment and transmission prevention. Hopefully, we will learn from this pandemic lesson that we need reliable, affordable, rapid testing for infections. And this is a key issue in this pandemic. And also, this pandemic is a great opportunity to learn about airborne precautions. They are effective if they implemented in an affordable and feasible way.
Great. And also testing for TB for those who are getting tested for COVID, because people just stop after COVID testing. We should also have, so this is a bi-directional kind of thing, you know, testing for TB as well as COVID in those people getting tested for one. I see the others more like comments. I hope I didn't miss any question there. Anybody who asked a question in the chat not covered, please speak up. I don't see any. Any last comments from our speakers or from Harry?
I'd like to thank everybody who participated, who joined, and welcome to Tuesday webinars on airborne infection control. It will continue next week on Tuesday.
Yes, thank you to all the presenters, and thank you again, Sahu, to Stop TB for hosting these ETTI webinars on airborne infection control. And just to follow up on what Grigori said, that the next 3 to 4 webinars over the next month or so for July will focus on environmental controls. Next week will be Paul Jensen talking about an overview of environmental controls with a focus on natural ventilation. The following week will focus on mechanical ventilation and room air cleaners, because we get a lot of questions about the use of room air cleaners. And then the following week will be, if I remember correctly, will be on germicidal UV or UVGI or GUV. So please look out for the invitations for the next webinars, but the next several will all focus on environmental controls and ventilations. But thank you all for staying. I see we're now 20 minutes past the end, so it's nice to see so many people interested and engaged. Thank you.
Anyone else? Yes, go ahead. If not, we end the webinar here and look forward to also getting connected with you every Tuesday. Please remember, every Tuesday at the same time. We will follow our social media and other outlets for information on topics and more details on how to register and so on. So thank you all. It has been a great discussion. And you will find this on the website soon, on both the Stop TB website and also the ETTI website.
Thank you, Sahu.
Bye, everyone.
Thank you.
Thank you.
Bye.
Bye.
Bye-bye.
Bye-bye.
Bye.